Earlier today, the Massachusetts Supreme Judicial Court cleared the way for voters to make a call on hospital staffing levels. The question headed for the November ballot would set a maximum number of patients that a single nurse could care for. The staffing ratio would vary depending on the unit. Supporters of the ballot initiative, which is backed by the Massachusetts Nurses Association, say it will help nurses better care for patients. Opponents say the staffing mandates will drive up healthcare costs without improving patient safety. The ballot question has sparked controversy. Should the number of patients that a nurse cares for be set in stone as part of a nurse's contract? Carolee McGrath sat down with Donna Kelly Williams, a registered nurse and president of the Massachusetts Nurses Association, to find out why she's in favor of this measure.
So this sets a very safe limit to the number of patients that are assigned to a registered nurse in the hospital setting, so that when you are in the hospital, that there is a safe limit to the number of patients that your nurse is caring for at one time.
So give us some examples of what kind of scenarios
we're
talking about.
Most patients, adult patients that are in the hospital, are in a medical surgical unit. And the nurse caring for those patients would have no more than 4 patients assigned at one time. However, built into this is an acuity system that would certainly offer an opportunity for nurses to take care of less patients if the patients warranted more nursing care based on their acuity at the time.
So there's already a limit set in the ICU in hospitals, correct? Okay.
And that was the result of a compromise in 2014 when we had done a ballot initiative at that time to set limits in all of the hospital units. However, at that time, the opportunity for the compromise for the intensive care units was offered to us. And at the time, that represented 40% of the beds in Massachusetts and really took care of the sickest of all of the patients that are in the hospital. And we thought that that was the best way to start.
And why do you think this is necessary to expand into other parts of the hospital care?
Because of the impact, number one, of the intensive care unit law, because it really is limiting just to the patients that are in the intensive care unit itself, the unit itself. We have intensive care unit patients that find their way to the emergency room, coming out of the operating room, and we need to make sure that with the limits in place, the patients are being cared for in the setting and with the limits in place that are the safest that they can possibly be in.
So you've been a nurse for a long time. You've seen a lot of things. I mean,
Over 40 years I've been a nurse.
I mean, have you seen specific things that made you say, oh my gosh, we need to change this?
I'm seeing more and more and hearing more and more from nurses across the state saying, the acuity of the patients, which means the complexity of their care, has increased so much over the years that just to get into a hospital is not that easy. You're only admitted if you're the sickest of the sick. And during that time, we have a short window of opportunity to turn it around so that we get you into the recovery mode or get you into the situation that your recovery can go on. And having so many patients at one time with these complexities, we didn't feel that we as nurses were able to care for the patients the way that we're not only trained to do, but licensed to do in the Commonwealth.
So opponents of this have said, for example, and you had mentioned the emergency room, that this really could jeopardize, the wait time, for example, in the emergency room, which obviously nobody wants.
Nobody wants to be waiting in an emergency room. However, if you can facilitate the patients that are in the emergency room, you can facilitate their care by the nurse caring for them, having less patients, and the nurses on the floor being ready to accept patients that are being admitted, you move that along a lot quicker. And we're not reinventing the wheel here. We have the state of California that already has limits in place, and they can tell you that this has facilitated the emergency room so that patients are not waiting longer than in Massachusetts. They're actually waiting much lesser.
And I think another concern that they have mentioned is the cost of all of this. The Massachusetts Health and Hospital Association had said there's a study that shows it would cost $1.3 billion in the first year. Yeah. And will that be passed on to patients, and how would hospitals manage that?
I have to say that I feel that that number is greatly exaggerated. All of the research that we have seen, and I've looked at this myself for the past 20 years as a nurse who's not only been working at the bedside, but has been listening more than I've been speaking for most of my career to all of the, you can't do this because of this, you can't do this because of that. And what we have found over the years is we have taken to heart everything that people have said regarding this ballot initiative, and we've incorporated all of the good points into this. And we have also been very cognizant of things like the actual cost of implementing this. And what we have found is that if we are able to take care of patients right the first time, and we prevent injuries to that patient, medical errors to that patient, readmission for the same thing of that patient back to the hospital, it is actually a huge cost saver, not a cost expense.
But the upfront is going to be like, whoa, for hospitals if this is implemented right away. And I think that is the concern of those on the other side.
I think it's fair to say that some hospitals are doing an incredible job at making sure that their patients are being cared for with limits already in place, and there are some hospitals that will have a higher level of maybe financial input that they're going to have to invest in caring for their patients. But for the most part, I think that the intent of everyone is to do the very best that we can in the area of health care.
What about allowing nurse managers and doctors in their own units decide how many nurses need to go per patient? I mean, don't you take some of that autonomy away when you pass a mandate?
As a nurse, I think that's what we have been under for most of my career, is asking other people to make these decisions. And frankly, I don't think that they have done the best job that they could do. As a nurse who is legally responsible for the patient that I am assigned and I accept the responsibility for, I have an obligation to that patient to take care of them the very best way that I can. And the research is very clear that if I have a limit to the number of patients that I'm assigned as a registered nurse, I can fulfill my obligation to my license. And just if we use the labor and delivery as an example, one of the most important and critical times in your life is the first 60 seconds, the first 60 seconds of your life. And to have a nurse assigned just to that baby to make sure that that transition is done safely and that any interventions that are required or needed are identified quickly is the most important thing that we can do. And there's another nurse that's assigned just to take care of mom because of any complications that could come up. And that's the research that's been done, and that's what we're looking for, is to apply that research to set this very safe limit.
Right. Well, Donna Kelly Williams, thank you so much for joining us today and giving us your perspective on this.
Thank you so much for having me.